Hi everyone, this is Kevin with nursingkamp.com, and this is my Fishbone course where I'm covering all the elements in the BMP, the Basic Metabolic Panel. And in this lab course, we're going to cover BUN and creatinine. Welcome to the Fishbone course where I'm covering all the 7 items in the Basic Metabolic Panel. From my resource found on nursingkamp.com, we're going to cover the BUN and creatinine today, the kidney labs. Protect the kidney. We're looking at the BUN and creatinine. Now, these labs are generally taken together, and so we're going to look at both of those together in the relationship with the kidneys. But first off, I want to kind of talk about the BMP. Now, the basic metabolic panel is 7 items that are included in this BMP, different lab values focused on electrolytes. Now, the first column, as we talked about, is peeing, puking, or pooping, fluid related. So any times of peeing, diuretics, pooping, diarrhea, puking, vomiting, or NG tubes, anything like that, is going to affect these 2 areas there. So that's very preventable because we kind of look at the underlying cause. The next thing is the compensatory mechanisms, which is chloride and CO2, which we talked about in the previous lectures. Now, those right there, we generally said, look somewhere else. Is the patient a diabetic? Are they a respiratory patient, or do they have Addison's, Cushing's, or cystic fibrosis? And we said that, when we're looking at this is generally the boat coming. All right, so let's look at the BUN and creatinine. And now we're actually, if you look here, that's K for kidneys. We're actually looking at kidneys right here. So whenever you're looking at the BUN and creatinine, think kidneys. Because kidneys are important for perfusion. They're also for electrolyte imbalances. And when we're looking at BUN and creatinine, we need to understand what is the relationship to these other labs. So let's look at the numbers first. So we have the BUN and creatinine. Okay, so the way I do this is that you have the CO2 here, right? So we said that 2 plus 2 equals 6, 22 to 26. All right, well, 6 plus 2 equals 8, so that gives you your 8. And then that 22 becomes here. So that will be a BUN. All right, and that's a BUN. All right, so the next one is creatinine. All right, so the way I think about creatinine is I think, the creation story. God created the earth in 7 days. Well, that gives me an idea. Creatinine, right? So, and that's 0.7, right? And so then I double that, and that becomes 1.4. Okay, and there's your creatinine. So those are my 2 labs, and that's what I kind of, they're ballpark figures. Now, I've seen these lab values a little bit all over the place as well, and we've talked about the gray areas and such like that. So when we're looking at these labs, it gets you the basic ideas, and then when you're looking at the NCLEX, we'll talk a little bit more about those lab values later on. All right, so let's get into the highs and lows of the BUN and creatinine, and then how do you look at this on the process? All right, so the first thing is high versus low. Remember, they're taken together. So, let's talk about that. All right. So generally is that you think of this is the vasculature. This is the body, right? So then it goes to the kidneys, right? The loop of Henle. I was saying peritoneal dialysis, PD, right? So proximal versus distal loop. And then this is the loop of Henle, right? So Henle. And we know that diuretics work on that loop. Now, I go more in depth about this during my renal lectures on intrarenal, pre-renal, post-renal. So I definitely recommend you go over to those renal lectures because I really cover this really in depth about these labs. So, and how these things get affected. So, but there's a principle that we have to see here, right? So you have this is volume, right? This is the vasculature, and then this is the kidney, all right? And then it goes out to the toilet, right, where it meets its maker. Okay, so we have the person here, the vasculature, we have the kidney, right? Then we have the output. All right, so understanding that, so this is the problem B outside the kidney. So BUN is the problem outside the kidney. Creatinine, flip this over, is a C. Creatinine is the problem inside the kidney. All right, so that's the concept. The concept is BUN, be outside the kidney, creatinine inside the kidney. Okay? All right, so now we understand that. So let's talk about high versus low. Let's deal with low first, right? So low creatinine, don't care. All right, so it's inconsequential to what's going on if the kidneys are working. So low we don't care about. What about low BUN? Well, the problem's outside the kidney, BUN, right? So low, LOW, liver, overhydration, water toxicity. Okay, that's it. So low BUN is either liver problems, so then I would look at the liver enzymes. Overhydration, then I would look at fluid status. Water toxicity, anything that's driving that. Right? So like somebody with lithium, different things like that. So low, that's it for BUN. And then that's it. Right? So let's go to high. All right. So here's the principle behind it. The first thing you have to realize is that high on BUN and creatinine is either acute or chronic. All right, so let's talk about it. So we just said that the BUN is elevated and the creatinine is elevated. All right, so let's talk about how do you look at this fishbone. All right, so we said that high is going to be the problem. As we said, low is liver or water toxicity, and that's about it. But high is the issue. All right, so let's go through the process. All right, so the first rule of this is we always look at the BUN first. Right? And once we look at that BUN, is it high or is it low? Okay, if it is high, remember the problem is outside the kidney. Well, how is the kidney functioning? Right? So if it is high and we go down to the creatinine and that is normal, dry. Okay? Problems outside the kidney, the patient's dry, period. Right? So rule is you look at the BUN first. If it's elevated, yes, go down to the creatinine. How's the kidney working? Okay. Oh, I'm working fine. Dry. All right? That's called a term that we'll call 20/1. Just a term we call it. All right? And that means a patient is dry. All right? So that's it. So that's first rule. Look at the BUN, elevated, yes. Go down to creatinine, normal, dry. And then we reevaluate other labs. What's the sodium like? Is this compensating and so on? All right. Let's go to the next step, step number 2. Look at the BUN. That's high. Well, how's the kidney working? Go down to the kidney. That's also high. All right. Stop. Circle both. Remember we talked about this before. Whenever you circle both of these in a diagram like this, this patient is more acute. We talked about that with chloride and CO2. You're just circling one, that's the boat coming. Hey, there's a boat. If you circle 2, that patient is more acute. They're becoming more decompensated. All right. Well, with the BUN and creatinine, if you just circle 1, they're dry, so you're assessed for dehydration. Well, if you go down to the creatinine and the creatinine is also elevated, you circle both of them. Then you say to yourself, is this an acute problem or a chronic problem? And you go down to the GFR, the glomerular filtration rate. All right. So we've talked about in the past with blood pressure. Well, blood pressure, if a person has a blood pressure of 100 on 60, is it low? Even 96 on 60. Well, that blood pressure, you can't take it as its own. So you have to say, okay, well, what's the mean arterial pressure? Right? Mean arterial pressure is what I call 3 dentist, 3DDS. All right. So diastolic plus systolic divided by 3. So what does that mean? So I just said, here's a blood pressure. 96 over, I'll keep it easy for myself, 50. All right. So diastolic plus diastolic equals, so diastolic plus diastolic. So this is 50 plus 50 equals 100. Plus systolic, which is 96. So this becomes 619. Divide by 3. So I go down here and I divide that by 3. Well, 3 into 19 is 6, so that's 18, and then 16, and 3 into that is 5. So I have a mean arterial pressure of 65. Okay. All right, what does that mean? Well, that's the perfusion. Okay, so let's talk about this. Why is blood pressure so important? Well, it's about perfusion. Perfusion to your organs. Blood flow and oxygen gets to your organs. Okay. Well, why is mean arterial pressure? Well, how do we know it's being perfused? Right? Just because a person has a blood pressure of 96 on 50, are they perfusing? And how do I know? All right, let's talk about the concept. The brain requires a mean arterial pressure of 70 to 75. If it's 70 or 75, mentation is there, alert, oriented, they're good to go. All right. Once it goes below 70, they're not perfusing the brain as well. Hypoperfusion. But do you see it? You might. Agitation, restlessness, all those types of things. So mean arterial pressure is important for perfusion. Perfusion of the brain and the kidneys. So how do I know the kidneys are affected? Well, 60 to 65 means that the kidneys are being perfused, okay? And so I shouldn't see an elevation of the BUN or creatinine, okay? Now, if the blood pressure was less than 60, these two labs would elevate. And that's called intrarenal. It's another lecture. We'll talk about intrarenal failure. All right. So let's talk about this. So the BUN and creatinine are elevated. Okay. So if the BUN's elevated, I go down to the creatinine. How well is that kidney working? If it is working fine, that means it's normal, 0.7 to 1.4, dry, also called 20 to 1. Second step, I look at the BUN. It's elevated. I go down to the creatinine. That's also elevated. I circle both of them, and I say to myself, is this an acute problem or a chronic problem? Well, I just talked about the acute one. The acute one could be your blood pressure is too low, right? The problem is outside the kidney, and it is affected inside the kidney. Hypoperfusion. Blood pressure is too low. Okay. So how do I know how well it's working? Well, whenever I circle both of them, I have a conversation with myself. I say, is this an acute problem or is this a chronic problem? Right? And then what I think about when I say a chronic problem, well, what do I mean chronic problem? Well, a kidney problem, like chronic kidney disease. Chronic kidney disease, long-term, over time, will make the BUN and creatinine become elevated. So that becomes chronic kidney disease. That's chronic problem. Call the doctor about that, but I have to evaluate that. So then I say, okay, well, how do I evaluate how well it's working? By the GFR. Remember the mean arterial pressure I just talked about? Well, the GFR is like the mean arterial pressure for the kidneys. How well is the perfusion through the kidneys? Okay, and that's what it means. Okay. So now we know that. So we have the BUN elevated, yes. Creatinine is normal, means the kidney's working fine. Second step, BUN's elevated, creatinine's also elevated. Circle both of them, say to yourself, is this a chronic problem? Is this patient diabetic? Do they have long-term hypertension? You know, chronic problems that elevated the BUN. But how bad are the kidneys functioning? All right, so here's some numbers. GFR. Now the basic rule is 60. Anything less than 60, they're going to become more toxic. Means they're not going to get rid of the waste products as easily. But they can be 80, 89, and this, that, and the other thing. Okay. So what's the GFR? It's the mean arterial pressure of the kidneys. It's a mathematical formula. So do we always look at the GFR? No. The only time you ever report on a GFR or talk about it is that the BUN and creatinine are elevated. So if I had a BUN of 32 and a creatinine of 2.2 and a GFR of 50, because both are elevated, so then I go down to the creatinine. I would report a BUN and creatinine of 20, 32, and 2.2 with a GFR of 50. Now, let's talk about the two pieces. We just said that there's a chronic problem, chronic kidney disease, diabetic, hemoglobin, A1C, 12. What about the acute? Well, a blood pressure low for a period of time, severe dehydration could cause an acute rise. Bleeding could cause acute rise, but also medications. And that's called cake man. And cake man are all things that can make the BUN and creatinine elevated. So that's why we assess these labs before a patient gets these medications, or we monitor these meds. And what does cake man mean? Well, C, cyclosporins, ACE inhibitors, Keppra, which is a seizure medication, requiring levels. Why? Kidneys. Erythromycin, the mycins, right? Metformin, amphotericin, NSAIDs, and sulfonamides. Okay, so here's the principle behind this. We have a problem inside the kidney that these medications could cause problems. So patients who have chronic kidney disease, you kind of tread lightly about these medications. So you might question giving these medications with these patients. Doesn't mean that you would give them, but they could cause problems, especially if they're going for contrast. If they're going to go down to a CAT scan and you give them a cyclosporin, and all of a sudden the BUN and creatinine were elevated, which one caused it? Was it the cyclosporin or was it the contrast? Okay, so I don't know which one it was. So the rule is that you don't give it. You question the order. So if a patient's going for contrast and is on, amphotericin, you hold that amphotericin, or you question the order. If a patient has chronic kidney disease and they're going to get amphotericin, you're like, wait a second here. The patient has chronic kidney disease. Should we give this amphotericin to this patient? Because the risk is increased problems of the kidneys. So BUN and creatinine, they're taken together. The first rule is you look at the BUN, and if it's normal, it's okay. Then the creatinine should be normal. But if it's high, go down to the creatinine. If that's also high, then you decide whether this is an acute problem or a chronic problem. Acute problems could be hypoperfusion. You might look at the blood pressure. You might look at dehydration, those type of things. But how bad is the problem? Well, you look at the GFR. And like I said before, you never ever report on it unless both are elevated. So let's talk quickly about the GFR and another rule. Okay, so we said we have chronic kidney disease, and then we have acute situations. Acute like hypovolemia. Well, hypovolemia would become hypoperfusion, decreased mean arterial pressure, which, if not treated, can affect the BUN and creatinine. Okay? All right, so we're talking about the GFR. In order to get to the GFR, we need both BUN and creatinine elevated. So the first rule is we look at the BUN and creatinine. BUN's elevated, okay. Then we go to the creatinine. How's the kidney working? It's also elevated. All right, circle both of them, then go down to the GFR. So we're going to take the acute one first. All right, well, acute is an acute problem. Solve the problem, no more problem. Okay, so the rule is with the GFR, with acute problems, is it's kind of like a spring. Once it goes down, you're watching it to go back up. So that's kind of the monitoring. So you're looking at this patient, and the BUN's elevated, the creatinine's elevated. You go down to the GFR is low, it's 30. Well, if I treat dehydration, I treat the blood pressure, I do what I'm supposed to do, I hold these meds, I should see the GFR getting better. If it continually goes down, you're not solving the problem. That patient needs further evaluation. Okay. Second thing with the GFR, let's take the chronic kidney patient. Let's take the diabetic. All right, so diabetics, we want the hemoglobin A1C less than 7. Right? Greater than 7, you're going to heaven. Right? 5 to 7, almost to heaven. You definitely need to be managing your sugars. 3 to 5 are you or I, not diabetic. Okay? And that's kind of the ranges. All right, so let's take the diabetic who's 12, hemoglobin A1C, not managing sugars. Oh, but I'm eating what I should be. Probably not. All right, so that patient, you monitor the BUN and creatinine. So you'll do a thing called a creatinine clearance, like a 24-hour urine, where you monitor to really, really, really look at this creatinine clearance. So they get a baseline of that. So then we have the BUN and creatinine are elevating, and we had a creatinine clearance, and we're monitoring this patient. Now they have an elevation of the BUN and creatinine. Well, if it's elevated, I look to the GFR. Well, they don't start to get toxic until less than what? 60. So as they go to, like say, maybe, for example, they're 55. Right? Well, at 55, they're stage 3, kidney disease. Okay? Now the problem with this is chronic kidney disease is running down a hill. Once you start to go down, you're not coming back. Okay? So all you can do is try to slow the progression of chronic kidney disease. That's all you can do. And how do we do that? Diet, exercise, insulin management, all that stuff. So in chronic kidney disease, the GFR continually goes down. Okay. What's the worst? When is it a big problem? 1.5. I like to think 1.5 is barely alive. Okay, what does that mean? Well, 1.5 is stage 5 kidney disease. 1.5 barely alive. What does that mean? Anybody who has a GFR less than 15 are most likely a hemodialysis patient. Has a shunt HD catheter, or they're just totally refusing hemodialysis, new onset type of thing. So that's an important concept. So that's why a chronic kidney patient who could go to 1.5, that's going to be a problem. Right? But what about the acute person? Can they go down to 1.5? Yeah, they got nephrotoxic medications that push them all the way down to a GFR of 12. Holy crap, they might need emergent dialysis or CRRT, continuous replacement therapy. All right, so let's talk about this. So we talked about high and low, not really low because low is low, LO. W, liver, overhydration, water toxicity. Okay, high is the problem. First question is if the BUN's high and the creatinine is normal, then they're dry. Treat the underlying cause. Second thing is if the BUN's high and the creatinine is also high, circle both of them and say, is this an acute problem or a chronic problem? Well, acute would be watch that GFR go down and then monitor it to go back up. A chronic problem, the chronic kidney disease, where are they on this hill? Are they getting to 15? And that's the big thing. Are they symptomatic? What do you mean? Well, the waste products build up. Nitrogen waste products. They become lethargic. They become sick. They get, itchy, all these type of things. Normal impurities that you try to get rid of aren't happening. So why are these kidney labs so important? Well, it's all about perfusion. We can kill those kidneys. So we try to protect those kidneys. And we protect them by monitoring this and knowing these medications and not giving two medications that do the same thing. So you wouldn't give a cyclosporin with an amphotericin. Okay, why? Because if the kidney labs go increased, which one did it? So that's where we always monitor that. So on the NCLEX, what does NCLEX test you on? This concept, BUN, creatinine, kidney labs, creatinine. If you have just a creatinine lab, then that's about intrarenal, inside the kidney problems, not the chronic kidney patient, the acute kidney patient. And it's usually about that. These are going to be the case studies that you look at when you're looking at your labs and with medications. Also understanding that kidneys are about perfusion. We protect them with the mean arterial pressure greater than 60-65 to keep the perfusion of the kidneys. All right, so what else do you need to know about that? That's all they'll test on the NCLEX, is just understanding, contrast with medications and, maybe GFR. And if you have a GFR in there, I don't think they're going to test you about acute versus chronic, just that that's a problem. And so if I was to test, is creatinine the true indicator of kidney disease or GFR? I would say GFR is the true indicator, because it truly tells you how well that kidney is functioning. It's the mean arterial pressure of the kidney. Where you think about, does blood pressure really tell you what the problem is, or does the mean arterial pressure do? The mean arterial pressure tells you truly how well they're perfusing. All right, so let's talk about the last part with the concept and why this is. Anybody can get this, an elevation of BUN and creatinine. So anybody walking around, dehydration, medications they take, that's why we need teaching, different things like that. Everybody can have it in the hospital because as a complication of the hospitals, the symptoms are elevation of the BUN, right, if they're dry, and a normal creatinine. The second thing is elevation of the BUN and creatinine is go down to the GFR. How well is that kidney working? Is it acute or chronic? Symptomology is really not important. It's more just about the understanding of the labs. The main concept is you have chronic kidney disease, you have acute kidney disease, and then you have medications that you could give that could cause this problem, and that's called KAMP. And KAMP are all medications that you need to know that you don't give together and with contrast, because like I said, they both come together, which is the problem. We talked a little bit about the perfusion of the brain, 70-75. Then we said the mean arterial pressure of the kidneys, 60-65. Q3, when do I call the doctor? If I've given medications and they have an elevation of BUN and creatinine, right? Or if they have an elevation of the creatinine, what numbers are too high? Any number's too high. That's the issue, right? They don't really dance too much around 22, 23. You're going to get 30 on a BUN, or you get a creatinine of 2. Anything 2 is too high, right? So that's the big issue. It's always about fluid status with the kidneys, pulses, yes. Cardiac, not necessarily, unless it's rhabdomyolysis. Rhabdomyolysis is a lot of cell breakdown that infects the kidneys. It goes into the kidneys and it can't filtrate it. Hemoglobin A1C, glucose is a big deal. And hematocrit, high is dry. That would be in it. Depending on the problem, acute versus chronic, being discharged can be an acute situation. It's a complication of medications that we gave or something like that. But BUN and creatinine is a key. If I have a normal BUN and a normal creatinine, I should see urine output. If I don't see urine output, what's going on? It doesn't make sense. It's either post-renal failure, obstruction, or otherwise. Well, that's about it. See my more advanced lecture in the renal section where I really cover this a little bit more in depth with intrarenal problems and post and pre-renal concerns, and that's under my renal videos. My name is KAMP, and this is Nursing Camp, and I can be found on social media, Instagram, and Facebook and YouTube. Please subscribe if you haven't subscribed now. Become a member. See you next time on the last one, glucose, where we look at glucose and what you need to know for NCLEX practice and nursing. We'll see you next time.